to AETCM, the emergency medicine channel. Today we are discussing how to localize a lesion in central nervous system lesions, especially in stroke and all. We'll see the pyramidal tract and we can make out where exactly is the lesion when we know about the anatomy of pyramidal tract. I'll draw the pyramidal tract so that you'll get an idea about that. So this is your brain. We'll take it as right side. Now we'll see the pyramidal tract. It originates in the motor cortex. This is pyramidal tract origin. Then these tracts will go to a structure called as internal capsule. So what is the difference between tract here and here is, here there are a lot of fibers that are spread across the brain area, but all these tracts will come to this small area and they will be condensed here. Okay, that is internal capsule. So this is internal capsule, and again the fibers from here, it comes down, same side it comes down. Then you have your midbrain, pons and medulla. In the lower medulla, these fibers cross to opposite side. Nearly 85 to 90% crosses to opposite side. So up to this part, we'll make out how to make a diagnosis when we have a lesion somewhere in the tract or in the brain. So we'll take a lesion here. Suppose it is a lesion in the cortex. It can be a stroke, ischemic stroke. It can be hemorrhagic stroke. It can even be a tumor. Okay, ischemic stroke can be rapid, patient develops rapid symptoms. Depending on the vascular area, they have some clinical differences. We are just trying to localize basic localization. So we will not be discussed in depth about how to localize ACA territory, MCA territory and PCA territory. You imagine that it's an MCA territory, middle cerebral artery territory. There is a lesion, maybe a tumor or an infarct in this area. You can see the lesion is here, but the number of fibers involved in that lesion is very minimal. You can take it as 1 or 2, 3, 4 fibers are involved depending on the size of the lesion. Okay, what will be the symptom of this lesion? We'll see what will be the symptom of this lesion, because the lesion is in the cortex. So patient can have features of raised ICP, patient can have headache, patient can have vomiting, patient can have some visual disturbances, patient can have weakness. We'll see what type of weakness this patient is having. So you have seen that pyramidal tract has come to the lower medulla and crosses to opposite side. So patient will have opposite side weakness. How the weakness will be? Only few fibers are involved. So the weakness will be minimal. So we'll see what type of weakness this patient can have. So this is patient's face. So lower part of the face is involved, that is UMN facial palsy. Then patient's left upper limb, left lower limb is involved. Now that is very important. So opposite side patient can have hemiparesis, opposite side patient can have facial weakness. But you can see the lesion is this much big, but lot of fibers are escaped from the lesion, so the weakness is minimal. So patient can have hemiparesis, not hemiplegia, hemiparesis, minimal weakness. But they can have associated symptoms like patient can have seizures, headache, vomiting, raised ICP features like bradycardia. All these things can be there. Some patients can have visual disturbance also. So that is about that lesion. Now we put the lesion somewhere here in the internal capsule. Same type of lesions only I am putting for easy understanding. So I put a lesion here in the internal capsule. What you have seen is lot of fibers are there in this area and lot of fibers are involved in this lesion. Patient has similar type of presentation because fibers are involved, but it will be more dense lesion. So dense hemiplegia is a feature of internal capsular lesion. Because the area is very small, all fibers are condensed to that area. So the lesion will, even if it is small, the weakness is very big. So here, comparing to this area, here weakness is very dense. So this patient can have hemiparesis on the opposite side, and this patient can have hemiplegia on the opposite side. Both patient can have UMN type of facial palsy. It is very important. Patient can have UMN type of facial palsy. This patient also can have some visual disturbances, sensory loss. All these things can be there, but predominantly it will be a motor deficit. So patient can have dense hemiplegia. Here hemiparesis. Associated cortical symptoms like headache, vomiting, seizures, all these things can be there when the patient is having lesion here. Now we put the same type of lesion somewhere here. What happens? Somewhere here what happens? Somewhere here what happens? So you know that this is midbrain. This is pons. This is medulla, lower medulla. It crosses to opposite side. So when the lesions are in this area, you can tell it is crossed hemiplegia or crossed hemiparesis. That is because when the lesion is here, the cranial nerves which is originating from these areas also can be involved. Okay, so you know that cranial nerves are originated from the brainstem, midbrain, pons and medulla. The major cranial nerves here will be 3rd, 4th, 5, 6, 7, 8, 9, 10, 11, 12, like that. So predominantly, suppose midbrain there is a lesion. What happens to the patient? We'll see. The lesion is in the midbrain. So where the patient will have weakness? Patient will have weakness on the opposite side. So patient is having weakness on the opposite side. Because the fibers are crossing to the opposite side, patient can have weakness on the opposite side. Which are the major cranial nerves comes in the midbrain? That is 2nd, 3rd, 4th. It mainly affects the eye. Patient can have ophthalmoplegia. So this side, on this side, patient can have ophthalmoplegia. They are called as brainstem syndromes. We will give a detailed description of all these brainstem syndromes at last. So this patient can have right-sided ophthalmoplegia and left-sided weakness. The type of crossed hemiplegia. Why we are calling it is crossed hemiplegia is because one side patient is having cranial nerve weakness, opposite side patient is having pyramidal weakness like upper limb, lower limb are involved. So, okay. Now we put the lesion, the same type of lesion in the pons, which is the major cranial nerve here, that is 7th cranial nerve. So what will be the clinical finding of this patient? I will draw here. Patient is here, face is there, upper limb, lower limb. So upper limb, lower limb is on opposite side. That is because these fibers are crossing to the opposite side. So patient can have opposite side weakness. But the major problem is 7th cranial nerve here is involved. This is the 7th cranial nerve. So what is the difference between this 7th cranial nerve which is involved in the cortical lesion and this one? So here right-sided full face is involved. This is a lower motor neuron type of lesion. That's why full face is involved on the right side and the opposite side patient is having weakness. So you can understand what will be the difference from this lesion to this lesion. This lesion also patient is having opposite side weakness. Here also patient is having opposite weakness, but the face is involved on the opposite side, that is same area of the weakness. Opposite side lower part of the face is involved, that is a UMN type of facial palsy. Whereas here patient is having weakness on the same side of the lesion, that is on the right side, patient is having opposite side weakness, and this is LMN type of facial palsy because lower motor neuron type of weakness seen in the 7th cranial nerve nucleus. So you understood the difference between a UMN facial palsy which is occurring in the cortical lesion and an LMN type of facial weakness occurring in the pons. Okay, so that is second type of lesion. Third one is if you put the lesion in the midbrain, upper part or relative lower part of the midbrain, pons and medulla. Medulla we are putting another lesion. Which are the major cranial nerves come here? This is after 8th come here, 9, 10, 11, 12. So this patient can have predominant weakness in the pharyngeal muscles. So right side patient can have pharyngeal muscle weakness, left side patient can have upper limb and lower limb weakness. So this is how we localize a lesion in the brain, internal capsule, midbrain, pons and medulla. So what will be the patient's clinical symptom or clinical features when we are examining the patient? That also we can see here. Now any patient who is having right-sided lesion, whether it is in the cortex, internal capsule, midbrain, pons, medulla, patient is having opposite side upper limb, lower limb weakness. So upper limb, lower limb weakness is there in all patients. When we are examining this patient in initial phase of the stroke or initial phase of the lesion, acutely patient can have LMN type of weakness. What is LMN type of weakness? All the muscles are flaccid in that type of weakness. When we are examining the muscle power is not there, tone is totally reduced or absent tone, and when we are examining the deep tendon reflexes, all reflexes are diminished. So weakness is there, tone reduced, tendon reflexes completely absent or reduced. So these are the three important features of LMN type of weakness. Acute stroke or acute lesion will produce a type of spinal shock, and patient can have LMN type of weakness. Actually it is UMN type of weakness, but clinically we feel that it is an LMN type of weakness because patient is having weakness, flaccid weakness, tone is reduced, tendon reflexes are absent or completely reduced. After some time or 1 or 2 days, it will become UMN type. Okay, so during that phase, if you examine the part of weakness, patient can still have weakness, but tone has increased. Tone increased, deep tendon reflexes all are increased, plantar extensor. Here it is plantar maybe mute. So this is the change occurring during the stroke. Acute phase, you have LMN type of weakness. It's only LMN type of weakness clinically, but it's actually UMN type of lesion. So acute spinal lesions or acute stroke, all patients you can have initially all the features of LMN weakness, then slowly it will become UMN. When the patient sets in that UMN type of weakness will be there, tone is reduced, increased, it is a spastic tone, then DTRs all are exaggerated, plantars are extensor. So we can localize a lesion if we know the pyramidal tract like this. We can easily localize, we can tell where exactly is the lesion. So once you know that what is the type of lesion, whether it is a stroke, that is ischemic stroke, hemorrhagic stroke or a tumor, you can order for a CT or MRI, because in acute ischemic stroke, if you want to thrombolize, CT will be the best investigation. After the golden hours of stroke, if you want to investigate, MRI with MR angiogram will be better investigation. If you think that it is due to a tumor, then MRI with contrast will be better investigation. That's why we should know what is the type of lesion, where exactly is the lesion, all these things are important. If the lesion is in the cortical area, CT may be helpful in acute phase. But if it is in the brainstem, CT may not give any good report during that acute phase. So once again I will tell you how to localize. You see the pyramidal tract, lot of fibers coming from the cortical area. A lesion like this spare many fibers, they are not involved, only few are involved. So patient can have mild weakness on the opposite side. Face, you have UMN type of facial palsy, that is only lower part of the face is involved on the same side of the weakness, but all are on the opposite side of the lesion. Now you come to the internal capsule, it's a dense weakness because all the fibers are densely packed in that area. So patient can have severe weakness, face also can be involved. Come down to the midbrain, patient can have ophthalmoplegia on one side, opposite side weakness. Come to the pons, patient can have 7th cranial nerve palsy on the right side, opposite side weakness. this facial palsy will be LMN type of facial palsy. Full face is involved. That is because all the fibers for the face is involved. Both upper part and lower part is completely cut off from the brainstem. That's why full face is involved on the opposite side. Patient have weakness on one side. Opposite side patient is having facial weakness. If you see the lesion, the face is involved on the side of the lesion. Weakness is on the opposite side. That is because the pyramidal tract crosses to opposite side. And the last one is medulla. Lower medulla, it crosses to pyramidal tract crosses to opposite side. So same side patient can have 9th, 10th cranial nerve palsy. So when you are examining the throat, you can see the gag reflex. All this will be diminished on that side. Opposite side patient is having weakness. During any acute lesion, patient is having LMN type of finding. After some time, it will become UMN type of finding. Other parts towards the spinal cord we'll discuss in another class, because there we have to see what are the ascending fibers, what are the descending fibers, what are the fibers which is coming close to the central part of the spinal cord. So you can easily localize the lesion in the spinal cord. And last part will be the neuromuscular junction to muscle. How to diagnose neuropathies and myopathies. That will be the last part of localization of lesions. Thank you.